You are watching the DOCtalk show.
Good evening, ladies and gentlemen, our esteemed viewers and fellow healthcare enthusiasts. Welcome you to yet another enlightening episode of the DOCtalk show, which is proudly brought to you by Quiz Mali Productions and sponsored by the Ministry of Health and its partners. My name is Dr. Muyanga Andrew Muyanga, your host this evening as we are discussing the topic of holistic care for patients and families facing chronic and terminal illnesses. And in-house with me this evening is a gentleman and a lady ready to do this discussion justice. I'll request, starting from the lady right next to me, that she introduces herself to the viewers out there.
Hello viewers, and good evening to you wherever you are. My name is Irumba Lisa Christine. I am a palliative care clinician and a pain specialist. I work at the Palliative Care Association of Uganda as the research and information manager, and I'm glad to be here.
It's a pleasure having you. Thank you for sparing your time to come and share your hard-earned knowledge with the rest of your fellow Ugandans. And Dr. Muwanga, I request you as well to say hi to the viewers out there.
Thank you so much, our moderator. Hello viewers, good evening. I'm Dr. Muwanga Moses. I'm an assistant commissioner and a clinical service at the Ministry of Health in charge of hospice and palliative care services. I'm happy to be with you and to share with you about holistic care for patients and the families in our country.
Dr. Muwanga, it is a pleasure having you once again on this show. As earlier noted, the topic of discussion tonight is holistic care for patients and families facing chronic or terminal illnesses. And I think we need to start from the point of understanding what is holistic care in your view, Lisa.
Thank you so much. So holistic care is the body, the mind, the spirit. So it is care that looks at your physical problems. And the physical problems could involve pain, which is usually the most common problem that people will come to the health facility with. But it can involve other issues like nausea and vomiting, chronic diarrheal diseases, and so many other confusion, so many other symptoms that the patient might present with because of a long-lasting illness they have. The problems can also be psychological or emotional. When the people are sick, their bodies are unwell, but their mind is also unwell. They are not settled. You know, they worry, what will happen to me? How will the treatment go? How will my family perceive it? Will my family look after me till the end? You know, how will everything, you know, play out?
Will I leave my children with?
Absolutely. You know, will my children continue to go to school? You know, who will be in charge of my property in case you have? You know, who will make decisions when I'm no longer able to make decisions? But will they make the right decisions that favor me? So a lot of psychosocial or psychological and emotional issues that the patient and also the family, will this person still be happy with us to look after him? You know, will they be comfortable at the place where they will be? You know, who will be available to take them for their reviews and give care? And sometimes these problems can be social, you know, also cultural. And with social issues, you know, if somebody, for example, is married, they are working class, you know, chronic illnesses sometimes will make you lose your job. Your employer will understand for a couple of weeks or maybe months. But after that, you're out of employment. You don't have money. You know, your wife, she has to work, she's away. You don't know who she's talking to. You're worried about, you know, other people, your children, they're not going to school. But also, people are also giving you a lot of information. That problem is not medical. You know, it's cultural. You know, you need to consult another person that is not medical, but a traditional healer who will, you know, cure your disease. And so it can bring about confusion. What do I, and especially if somebody has a problem that can sometimes not be justified medically. But if it's also justified medically, you need to spend time explaining to the person that this numbness you have in your feet is not because you stepped on something, but your nerves are affected. This confusion you're getting could be a side effect of the medicine or actually the problem that you have. And then they could also be spiritual. Why me? Has God forgotten me? Has God neglected me? Did I sin too much? You know,
I annoyed the ancestors.
Absolutely, you know. So that is what holistic care is. It's a whole cocktail, if I can use that word, of, you know, issues that can affect.
So you're saying it's the kind of care we give to someone who is, to the patients and families experiencing, patients experiencing chronic and terminal illnesses and their families.
Yes.
But this care is given cognizant of the fact that a human being is not just physical.
Yes.
But they have a psychological dimension to them,
Yes.
a spiritual dimension,
Yes.
the cultural.
Yes.
Interesting.
Yes.
Thank you so much. But Dr. Muwanga, why holistic care?
Thank you, moderator. I think it's holistic care, just as my colleague was defining it. Once somebody gets a chronic illness, it does not only affect the body, it affects the mind and the soul. You find the entire person is being affected because, as we define somebody to have disease, it's not only the absence of disease, but the mind and the soul have to be well. So when we are caring for these people, we have to think of all those aspects of life, including his environment. These are people caring for that person and the children. So when we are managing a chronic illness, we think of a disease which is not going to heal today. It's a long term until when that person lives for 50 years or so, or less than that. So when we are caring for that person, we need to engage in different dynamics. Just as Lisa was defining, that we need to look at the physical ones which that person is having, looking at even the symptoms being caused into that by that disease, being mindful of his mind and soul, whereby somehow we have to prepare this person as well as preparing the family. Many people look at the person who is suffering without knowing the family around, including the children. In many cases, children are forgotten. To know that daddy has a chronic illness, we need to explain to this child that he's going to live like that. Or if the child has an illness, the mother needs to appreciate that this illness will never heal, because they always move from one doctor to another trying to seek for remedy, including the traditional doctors. So we need to have that dynamics of making the person understand that the spiritual, the psychological, in all dimensions, whatever can support this person to live a quality of life, we need to make that person's quality of life to be meaningful, not how long it is, even if it's for a short time, but it has to be a full package of that.
That is wonderful. You know, when we're thinking about this topic, we said holistic care for patients and families facing chronic or terminal illnesses. If it's the patient experiencing this terminal illness, why do we go ahead to involve families as well when we are giving this care? What is the essence of involving families within this management?
So, holistic care is important for the patient and family. It improves the quality of life, but also it enables them to make informed decisions about, the treatment and the goals of care. What do we want to see at the end of it all? And I was mentioning that why involve families? The patient belongs to the family, and they didn't just fall from the sky and come, but they have a mother, father, brothers, sisters, neighbors, uncles, cousins. They have people that love them. They have people that need to understand what's happening. And I would like to use the words of, I think, Hippocrates, the father of medicine, who said that it's more important to know the person that has the disease than the disease that person has. So when you know the person, you know everything that affects them, and that will include their family. So when you know the family circumstances, you will know who to talk to, who is the next of kin, the responsible, who will make decisions that are critical for the care of this person. But they also need to understand and be comfortable that dad has this problem, and this is how we can contribute, because they have a role to play in the care and management of this patient.
Lisa, forgive me for cutting you short, but let us have a short commercial break and we shall be right back to continue with this discussion.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk show. You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
We welcome you back from that short commercial break. This is the DOCtalk show, proudly brought to you by Quiz Mali Productions and sponsored by the Ministry of Health and its partners. The topic of discussion this evening is holistic care for patients and families who are facing chronic or terminal illnesses. And in-house with me tonight is Dr. Muwanga on my far left, and Lisa right next to me. In case you have any comment to make, please feel free to send in that comment via the number displayed on the screen or via our Twitter handle as well. And we are reminding you that we are even streaming live on YouTube, so you can check out our YouTube channel. We left off on a point where we were asking or responding to the question of why we need to involve families, and certainly Lisa enlightened us on the fact that we did not fall from the sky. Patients belong to families. They have fathers, they have mothers, they have sisters, cousins, and so on. But the other aspect during the break which we talked about is the fact that family is the major support that a patient has, physically, psychologically. They are the people who are going to help this patient in case there is any medication, for them to adhere to this medication. In case the patient feels fed up of life, because Dr. Muwanga, there are people who have terminal illnesses that are pushed so much that they want to commit suicide. But family at times is the reason why people refuse to commit suicide. I mean, who am I going to leave my children with? I don't want to leave my husband for anyone. I don't want to leave my wife for anyone. So family is so important. But we are going to proceed and explore the topic of the various aspects of holistic care. As they said, it is bio, psycho, spiritual, social. So I think we shall start with Dr. Muwanga to take us through the biological or the physical aspects of holistic care we provide when giving palliative care.
Thank you so much, our moderator. I think just as you defined it, our people have their different aspects of handling the person with chronic illness. And the biggest, basically, which people see are the physical, the biological aspects of palliative care. Here, when a person has that chronic illness, not every time that a person may need drugs. There are times when a person may need drugs, that is pharmacological, but there are areas whereby there are no drugs required. And the major problem which people suffer from physically is pain. Pain per se also, we at times in palliative care, there is what we call total pain. Pain can be physical. Person has got an injury, has got some broken area, has got a cancer which has moved somewhere and is really having physical pain. But at times pain can be spiritual. Person feels he has pain, but he can only be helped by spiritual remedy. There are times when pain is economical, social. So somehow when a person in palliative care, you need to assess, and at times even we go ahead and score this type of pain, because not every pain is given the medication, depends on the gravity of that pain. So at times we don't need drugs, it's non-pharmacological. You know, somebody comes with a problem, you don't need drugs. You may at times, you know, some patients say, I went to the hospital, but my person, they cancelled us, they gave us this. There were no drugs given.
They don't know what
they feel that nothing was given, and they gave me this something very little. So we, apart from pain, there are other symptoms which are results of the disease per se.
Yes.
Patients can get a lot of vomiting. At times they feel nauseated, they don't want to eat anything, they feel dizzy. Some of them even feel they cannot breathe, you know, they have distress whenever they are sleeping. Just being given the non-pharmacological whatever of propping up a patient, position that patient properly. And he says, the doctor gave us nothing, but my patient got better, but at least we needed some medication. Some people, because of the illness, they get constipated.
Yes.
Some of our patients, because of some chronic illnesses, they get incontinence, you know,
Yes.
and at times we give them just a simple procedure of catheterizing. You know, you put a tube in it, you remove the urine, and they get a relief. But the caretakers, just as we say, the caretakers are involved, they feel not much was given, they look at the medical part of it. So in palliative care, there's a lot we give apart from medication. Idea of palliative care is more holistic, because how do you help that person live a quality life? Not medication, but that life which makes that person very comfortable. At times people need to be propped up, move a bit outside, breathe some fresh air, interact with the people they really feel they need. Times we get some patients who tells you, can I move out? Can I move my chair outside just to breathe? And they feel that life, which makes them a bit better. So when we look at that component, let's not look at only drugs. Let's look at other aspects of life. But there are others who really need drug. The pain is so much severe. And at times, the commonest drug we always use is morphine. Many people have phobia for morphine, and they think that if they keep on increasing the medication for this morphine, my patient will get addicted. But we tell them that this patient needs that medication. The pain is the one which makes that person's life very complicated. So I'm calling upon the audience that once you have a patient and whatever the doctor gives you, either pharmacological, non-pharmacological, please appreciate and let that patient receive that medication.
I thank you so much, Dr. Muwanga, for the submissions. While you are making that submission, you talked about handling issues such as urinary incontinence. And we know how embarrassing it can be to move out as a mature person and your pants are soiled or you have urine all over you. So I think what you have talked about also has an aspect of ensuring that this person actually exists with dignity as well, and which we really appreciate. And next, I think we have to think about the other dimension of holistic care, and that is the psychological or the emotional aspect. How do we handle that within our context?
Thank you very much. The very first thing I'd like to mention is that I hope this discussion will give the patients and caregivers confidence to speak with their nurse, doctor, or their palliative care provider. It is okay. Sometimes I've been in the clinical room, and when the patient tries to raise some of these issues, the family will say, no, we will not discuss those here.
Or to swallow.
Yeah. but they are very valid because your provider will give some information that will help you cope better with the illness as a patient, but also the family at large. So continue these discussions with your healthcare provider. So, for example, some of the psychological issues they'll have is why me? And sometimes these problems can be helped with just counseling and conversations. But we've also seen instances where people fail to cope and they'll need a clinical psychologist or a psychiatrist to manage their complex mental health issues that resulted from poor coping mechanisms of their underlying problem. So it can be stress. This stress can be brought about by the disease because you're not able to handle. I don't have money. Will I cope with the treatment? The medicine is, for example, in cancer, the medicine is strong. Some people still feel shame. I have cancer, I have HIV and AIDS. How will the people hear that I have these problems? So they are worried, they are stressed. But nobody will come out of this life alive. And in fact, the statistics tell us that
Please repeat that statement for me.
nobody will come out of this life alive.
Okay.
We will all die. And in fact, the statistics tell us that I think about only 10% of the population dies from calamities, accidents, and but almost all of us will have a life-limiting illness. It means we will be diagnosed with an illness, we will be sick for a very long time. So it gives us a reflection of what would I want? That is the stress, the worry, the anxiety. And now we can talk about some of the social problems. When you're sick, we've already briefly mentioned that you could have relationship issues with not just the people you live with, but with your relatives, with the people you work for, your neighbors. And, you could say that when they look at me, I've lost weight, they demean me, they do not understand that I'm the head of the house. But yet when you sit as a family and still continue emphasizing the roles of the different people, then the people are able to cope up and manage. And sometimes, especially old people will have sexuality issues, but even teenage people, their body image. Do I still look as responsible and as attractive to my partner and to other people? So if you explain that to your health worker, they're able to give you some advice on how to cope. Yes. And cultural issues, this is very important. In Uganda, before people go to hospital, they have visited the Dr. Gugu, the traditional person in the community. They have asked what you think. You've also clearly reminded us that some people will think of witchcraft, an ancestor, unfulfilled demands for the past. So as a healthcare provider, you should be able to appreciate that people have these, perspectives, and they're very valid. That's what they believe in. But your role is to guide them. Okay, that's happening, but I will do this to make sure that your problems are well managed and that you have a good quality of life.
Wow, thank you so much, Dr. Lisa, for those submissions. Allow us to have a short commercial break, and we shall be right back to continue with this discussion.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk show. You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
Welcome back from that short commercial break. This is the DOCtalk show, proudly brought to you by Quiz Mali Productions. And the topic of discussion this evening is holistic care for patients and families facing chronic or terminal illnesses. We left off in a point where we were discussing the social and cultural dimensions of holistic care. However, during the break, Dr. Muwanga raised an issue which I believe we need to talk about. That is how chronic illnesses generally and terminal illnesses affect the sexuality of patients and their families generally. I think Dr. Muyanga, you.
Yeah, thank you so much, moderator. I think when somebody gets a chronic illness, we can look at diabetes, we can look at hypertension, even the cancers, especially the male partners. You find that they become partially impotent, because we can't say they're impotent, but partially because of the illness. And at times it can be because of the psychological thinking. At times, you know, that whole system is affected by the blood flow. Many of our patients, when they become chronically ill, they become anemic, and then it affects their erectile dysfunction. So when we are running some of these clinics with people with their chronic illnesses, this is one area which is raised, and many people have a taboo to talk about it. As a family, if a couple comes, the gentleman wants to talk about it, the lady feels shy about it. And at times when he comes with a caretaker, she's a bit a daughter with a father, then some of these things are ignored. So at times we advise that there's need for privacy when we are providing palliative care, to open up, to discuss some of these areas. And one of the areas which is affected is the sexual function of the people in that area. And there are some instances where you find that somehow the partial impotence becomes almost a long-term impotence, whereby it's going to affect the family. People at times become biased, whereby the gentleman, if the gentleman who is sick feels it's affecting him as a person, but the lady is even also affected in that area. So we take through them through a counseling session, which is not easy per se, because telling somebody, you know, this is a chronic illness, you live with it, it becomes very difficult to make that gentleman appreciate. We have got scenarios whereby we have got cancers of the penis, and at times we are making a decision of amputating this. You know, this is a man who is married to a wife. He feels, really, I'm going to become almost not a man as per se. Do you need life? Do you need this organ? You know, these are decisions which are very difficult to make. So we see that as a family, you need to engage them. You need to engage the family. You need to listen to their issues as health workers. Find out what hurts most. At times we think of the disease, but the process. Somebody has diabetes. It's so not easy to understand. But when you go into a diabetic clinic, the commonest problem of men is impotence, partial impotence.
You know, Dr. Muyanga, as you are talking about that, I am trying to put myself in the shoes of the wives. When you are telling us that your husband will not be able to function as he used to function, the way I interpret it is, you are telling me that you going forward for the next 30 or 20 years are going to be starving, and that is not easy news to stomach. But let us leave that point where we have ended and continue to the spiritual dimension, because we said there is the biological, there is the psychological, and there is the spiritual. Lisa, kindly take us through that.
Yes. Thank you, Doctor. There is no injection for holistic care. We can already appreciate the role of the different players, the role the different people have in holistic care. So in terms of spiritual problems, here patients be searching for meaning, what makes meaning to their lives. In Uganda, most of the people will belong to a certain religious sect. They can be Christian, they can be Muslim, but they could also have traditional religions. So my role as a palliative care provider is to understand and appreciate and recognize the spiritual problem the person has. And if I'm not able to support, I'm able to refer to a spiritual caregiver. But, you know, it could be, why me? You know, why do I even have to seek health care if God has punished me with this illness and I'm dying? What is the importance of continuing to commune with other people? But the spiritual caregiver can guide them to, if they so wish, to continue practicing what gives meaning, if it's spiritual songs, if it's continuing to go to church, or if it's bringing the church and the mosque home for people to congregate with this person if they are very seriously unwell. They might question, so the role of the provider is to recognize and receive their pain and then offer support.
While talking about that, I was actually thinking about the need for us as healthcare providers to respect the spiritual preferences of the client and not to force our spiritual preferences on clients. If I'm a Muslim or if for example, I'm a born-again Christian and my patient is a Muslim and believes that talking with a sheikh will help him or her, it would be very wrong of me, irrespective of how much I believe that my God can work for that person, to force them in my direction. So we need to be cognizant of that, because trying to force this patient may actually worsen what they're already going through at the end of the day.
Absolutely.
And I'm speaking this strictly from a medical perspective.
Absolutely.
Yes. Now, going ahead, we are talking about chronic illness, but we've also talked about terminal illness. And at the end of the day, we need to come to terms with the reality that we are dying at the end of the day, and we are going to leave behind people. Dr. Muwanga, how do we help these patients to maneuver these avenues of death, dying, and bereavement?
Thank you so much. You know, when you go into a chronic illness, then a terminal illness. Terminal means that your illness has reached a certain stage whereby it's an advanced stage. Many of us fear death. No one doesn't fear death. But death is a must. It's death. Dying is also a process. And after death,
We are all dying.
we are all dying. So once you get a chronic illness, it takes a bit of a period and it keeps on showing signs that you are ending there. The doctor tells you today, we are giving a lot of this medication, we are removing off this, and then we are adding more of the palliative care, more of the painkillers, more of the psychological care. We need to bring the family and the person to understand, to appreciate this. There's a process. But in many cases, we fear to make people appreciate that it's a process. Death is a must, depending on the level. And how you prepare our patient matters so much. Because as the signs keep on showing that really the person has reached stage 4 cancer, then you need to prepare this person. He needs to do many of these other things. You know, he needs to improve his spiritual, his relationship with God. He needs to how to prepare the family. How is he going to live with the family? In many cases, we ask people, if you are given something like 2 months to live, what are some of the priorities you do? Those are the things which matter so most for your family, for your wife. These are things which matter so much. Then even after death, this is what we call bereavement. In many cases, the person who is dying, he understands and appreciates that, yes, I'm going to die. But after death, what happens? With the wife, with the husband, with the children. Even in the process of death, these children have to come in terms that daddy is dying, mommy is dying, and they need to share, they need to relate with that person. After death, people appreciate that in different formats. There are people who understand that somebody has died, they mourn for a short time and they give up. There are others who stay with it chronically. they keep on getting episodes removing that person. Some of them even refuse to remove the property of that person. It all depends and it varies from individual to individual. There are others who get episodes, they appreciate it and they accept that, oh, my child has passed on. Then after months, they keep on getting a relapse. It all depends on how that person who has passed on was relating with this person who has remained. So that period of death and dying is a period whereby the family has to come close to the one who is dying, so that the one who's dying appreciates that I've talked with my children. I think I've left my family in a good process. There are many scenarios where the person who's dying has been denied that interaction with the family, and we have had messes. The people don't even make wills, and this has caused a lot of messes, especially in polygamy families. Somebody thinks this is how the father is going to make a will, then suddenly it becomes different. So as we are preparing death and dying, everybody knows he will die. You need to prepare yourself. You need to prepare your family. And if God gives you that time whereby you can interact with your family, and we as health workers, we need to guide. We need to bring the legal fraternity to help and guide some of these people in that period. Although it's very difficult to manage that season of death and dying and making a decision. Worst of it, if people bring in, if it reaches a scenario of going to the ICU, of going abroad, because at times people are taken away from their family for a long time, and many changes take place. By the time the body is brought back, many things have happened home. So that death and dying is something we need to appreciate and support these people with chronic illness.
I want to give a disclaimer, Dr. Muwanga. I personally don't fear dying. Yes. But anyway, all in all, I've appreciated the fact that you've told us that our role goes beyond giving morphine. But we need to help the patient to process whatever they are going through, and the family as well, and to offer clear advice concerning the financial decisions which are inevitable over time by virtue of the condition that this patient has. I appreciate that. Allow us to have a short commercial break, and we shall be right back to continue with this discussion.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk show. You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
Welcome back from that short commercial break. This is the DOCtalk show. We are airing live on YouTube. However, in case you would like to join the discussion and submit your comments, please feel free to do so via the number that is displayed on the screen. You can also do that via our Twitter handle. The discussion this evening has been holistic care for patients and families facing chronic or terminal illnesses. And we were discussing the various aspects of holistic care that we as medical workers, together with the various members of our teams, need to institute. So right now, I think there is an important aspect or dimension to holistic care that we would like to request Lisa to help us to understand better, and that is the financial aspect.
Okay. Thank you so much, Doctor. So I would like to mention that in Uganda today, if we all, as are listening now, reflect, we will know somebody that is very unwell in our community. And when people are unwell, they go through financial challenges. You know, even when people are wealthy, which is very possible, they will feel the financial pinch that sickness brings to the pocket. And so a palliative care approach that we've been talking about can enable people make better financial decisions. So instead of leaving people very poor and impoverished to seek treatments that are sometimes are not so beneficial to the goals of care, but just because we'd like to try them because we want them.
Or to convince them that we are doing something.
Yeah, to convince them that you're doing something. I think it's a disservice to the patient. So if a health worker is able to have these conversations, the family can make a decision and say, you know, there is this that you're talking about, but maybe we shall have this option, you know, that we are able to afford, that goes within the means. You know, you will find people sell their last house and they're homeless. They have to seek shelter at a neighbor's or at a relative's. They have to get loans in the bank, then they have to hide because they can't pay back the loans. Clearly, you get a loan to seek medical care, but then how will you pay the loan with the interest? Because you're not working. So it's important for us to have these discussions with people and make better financial decisions, but because our expenditure is out of pocket. So if it's out of pocket, it means you'll spend each time you interact with a health worker. But when you have these conversations with your healthcare provider, you're sometimes able, or most of the time able, to make informed decisions about the treatment plan. Because as we've seen, some of these interventions are really from discussing with your provider. You don't need a tablet, you don't need an injection, but you need a compassionate person who will hold your hand, offer you love, bring a message of hope and say, I'm here for you. I'm here to listen and receive the pain that you're going through. Yes.
You know, while you were talking about that, I was remembering a certain old man. I was part of the team that treated him. We later found out that he had stage 4 cancer. And I've never forgotten, this man said a few words. His children were doing the doctor shopping we talked about earlier. And he reached a point and told them that I will not sell everything I have and leave my children with nothing when I am sure that I am soon doing what? Soon departing. Take me home and I see my grandchildren. And when God wills, I will go. And the children were resisting what he was saying. And I think this is where I think as palliative care providers would probably come in to help give these caretakers, yes, we understand their perspective. You are my father. I want to do everything physically possible to see to it that I see you longer.
Yes.
But nature has dictated that you must go. So I think it's our role to help them to come to terms with the sad reality that someone is going.
Yes.
Leaving that aside, Dr. Muwanga, can you help us to better understand sustainability of holistic care within our setting for such patients, and probably to help us to look ahead and think of future directions we should expect in relation to this?
I think following our discussion and having appreciated what palliative care all includes, it's more of holistic, it's multi-direction. I think to sustain it, we need multi-sector approach. We need everybody to be players into this. If we are to provide holistic palliative care, we need all sectors to be part and parcel of the approach. And if we do it that way, not only Ministry of Health, Ministry of Gender, Ministry of Agriculture, Ministry of Finance, even the local governments, because you know you need even the spiritual people, you need food for these people. It's a multi-directional approach. So if we bring all players into board, I think we'll have a plan which will sustain this. And in the ministry per se, we are looking at it being integrated. We have to integrate it in all departments. not running it as a vertical program, but it has to be everywhere and everyone inclusive. Because even the spiritual part of it, a nurse can provide, you don't need to bring a reverend. I think you can pray for that person. You can provide legal advice to that level you have as being it integrated. But at national level, in my division, we are currently ongoing. There's a national strategic plan. You know, this plan is a blueprint which will guide all players into that. It's almost done, and this will help us to guide us in each area. How will palliative care be given at all levels in our section? But we are planning that we cannot do it alone. We need networking. Locally and internationally, we need networking and collaboration. We have the Palliative Care Association. There are so many players in Uganda. People are providing even home care. People are providing spiritual care. People are providing services as individuals. That association has brought them together. Palliative Care Association of Uganda. So as ministry, we work hand in hand with these people. Even referral. If you have referred somebody in a far distance, let's say in Chisoro, we know there's a certain hospice in Kabale or Chisoro. Can we refer that person through that hospice, Kabale Home Care? You know, we work hand in hand. You know, this is something which will help us to sustain. And as a continent, we also have African Palliative Care Association. Africa, locally we have an association for Uganda, but on the globe, no, the continent as Africa, we also have an association bringing out all the players into that area. So we work hand in hand with these people. And I'm happy to inform the people that the offices of APCA are in Uganda. Wow. They are seated here when the decision was taken, Uganda, because Uganda is doing, I think we are at a certain level in palliative care provision. So the offices are here. So we are taking advantage of that, that global, continental association. Then there's also a World Association of Palliative Care. So we have been working into all these associations to see that we network. That's why when we are celebrating our Palliative Care Day, it's a worldwide, continental, and a Ugandan program. Another area we're not forgetting is research. We're doing a lot of research to find out some of these things, because this is an area we are not doing so well, but we are there. We have a research agenda, and we are working hand in hand with the association to see that whatever people talk about, we want to find out. How are the people finding it out? Like my colleague was discussing about the financial implications of people died. But what is the reality? It may be worse. It may be better. It's sending people abroad. What is the implication? You know, these are areas we need to research on. And we are happy to say that as a country, we are also holding conferences to discuss what comes out of some of these researches. Researches in palliative care, researches in the cancer, and I think we held one. We are holding one
next year.
Each year we are having a conference in palliative care and cancers. This can help us to sustain, but also to guide us for the future direction, looking at the global, continental, and our local.
Wow, that has been a comprehensive response. We are grateful for that. Lisa, in a minute, I'm requesting you to give our viewers your parting shots.
Oh, thank you so much. Thank you so much for having us on this show. And the future of palliative care in this country is very bright. We already can see a lot of innovations and embracement of technology. We have a Pikau Cares app that you can find on the App Store and Android. And on the app, you can learn more about palliative care, the latest developments, you know, some myths and misconceptions, as well as where to access palliative care from. We would like to continue using all the platforms available to share palliative care information. And I work with Pikau, and one of the objectives is advocacy and awareness creation. We would like to see that people are aware of these services and they can seek them at the places that are most convenient to them. And if you're a patient or caretaker, don't feel shy. Have the conversations we've talked about today with your palliative care provider, and you will feel better, but your quality of life will also be improved. Thank you so much.
Thank you so much, Lisa. Parting shots from Dr. Muwanga in 2 seconds.
Thank you so much. I think we need to come together as all players, because where we are seeing, we are anticipating that the palliative care needs are expanding because people are becoming aware of the chronic illnesses, the style we are living, and we think that if we become as players, there's a lot we can do to save our people and have them have a better quality of life. Thank you so much.
Thank you so much, our guests, and certainly to would bow down treason if I didn't thank our esteemed viewers for having tuned in and listened to us. This has been the DOCtalk Show.
This message is from the Ministry of Health with support from partners.